Good morning, everybody, and welcome to the Readmissions Refuel Project Wrap-Up webinar. We have just a few housekeeping items as we get started this morning per normal. We want to ask that you please do take a moment and check that your phone lines and your computer audio is on mute. We appreciate your attention to this as it does help us avoid the background noise during our session. We are using a meeting versus webinar format today because we have 9 of our hospitals speaking and presenting during portions of today's webinar. So we'll be unmuting a lot of their audio, so it's hard to keep all phone lines manually muted. So do just take a quick moment now, check your phone line, make sure that you're on mute, and that if you've got computer speakers you're using for audio, that you've got those muted as well. So thanks for attention to that. Also, we're going to be utilizing the chat box today, but I'm going to ask that you consider using it in a little bit different way. As I mentioned, we've got a lot of our colleagues speaking on today's call, so I really encourage you while they're presenting just to use the chat to engage with them and encourage them, ask them for resources as appropriate, etc. And of course, today's session will be recorded and transcribed. You'll have access to this recording and slide deck in the coming days as it'll be posted on Innovation. My name is Kate Carpenter, and I'm a clinical quality consultant and project manager for the Compass HIN. The other advisor on this project has been Dr. Amy Boutwell of Collaborative Healthcare Strategies. Welcome to today's session. So without further ado, I'll tell you we have a very full hour, and so we want to welcome and get through these introductions and certainly spend some time recognizing this cohort. But today's webinar is really all about recapping our work and sharing our successes throughout this project. So as you'll see, as we move through each phase of the project work, we're going to take some time to highlight some of the hospitals in our cohort throughout today. So the first thing I want to do is recognize this cohort for all of the work they've done on this project. Your commitment and your dedication to this project is really evident in your successes, and I think you'll all see that today. On behalf of the entire Compass HIN team, I really want to thank you for your hard work and your commitment towards reducing readmissions. This project began back in January, right at the beginning of the year, and went over the last 6 months. It was broken down into 3 different phases of work, each phase kind of designed to address specific topics and containing some specific action-driven tactics and items for hospitals. So let's recap phase 1 of our project work. So when we started into phase 1, we really made 4 refueling stops. We asked you to refresh your readmissions data analytics, use the data-informed targeting approach. We asked you to take an inventory of all your existing efforts and current resources. And then we really challenge you to engage a hospital-based and a cross-continuum team that serves or could serve, if you worked on it, your target population you identified through your data in phase 1. So digging just a little deeper into that first refueling stop, which again was to refresh our data, we really challenge you to take a fresh look at comprehensive readmission data and all the different components that entail. We provided facilities, both facility level and network level readmissions reports to jumpstart and inform your efforts. And we also provided you, or directed you rather, towards some tools and resources that we thought you could use and might assist you in mining through your own data sources. We asked readmissions teams to really think about who do you consider at your individual facilities and your communities, who do you consider a high risk for readmission, and why? Why those patients? And can you think of any, pressing on that button a little harder, can you think, or do you know of any high-risk patients who don't fit that current criteria? And describe why you think they're at risk. The second refueling stop, we said use that data to develop and make a very targeted aim. Think about what your data shows, and then think about what you should focus on. And when you know who you should focus on, what services should you deliver? As we talked about, we said take inventory. Think about, take time to pause and look at all the different efforts currently underway in your hospital and in your community. And then we referred you to Aspire Tools 3 and 4, those hospital and community inventory tools, and said take a look at everything that's currently going on so you know where the gaps are. And lastly, but certainly not leastly, was just refresh and refuel your team. Take a look around the table. Who is missing? Who do you still need to pull in? Both looking at your hospital team, who meets in your own four walls, but also who does it take? Who do you need to partner and collaborate with outside of your walls through your community to create successful transitions of care? I wanted to share with you a few of the wins from the phase 1 of work that were captured in the project pre and post surveys. So we learned in the pre-survey that only about 60% of hospitals, or that, yeah, 60% of hospitals did not really understand how that we were measuring readmissions. And so, of course, that makes improvement difficult if we don't know how we're being measured. So in learning this early on in the project team, our project worked really quickly in partnership with the Iowa Hospital Association to produce a couple of resources to help with this. We worked on a 30-day readmissions measure methodology guide, and then we also recorded a short webinar and sent out that link that kind of walked through the guide and explained the 30-day readmissions measures in detail so that hospitals could continue to have that as a resource to reference back to. The post-survey, though, did show this month that now 95% of hospitals have a solid understanding of the methodology we're using to calculate 30-day readmissions for the Compass 10. So I think this was a really great fundamental win. We also asked how often your readmissions teams meet. And at the start of the project, we learned that only about 40% of teams were meeting at least monthly, and 15% of teams weren't meeting at all. And then another 25% of teams weren't meeting consistently. And so you can see on the right, when we've asked again here in June at the end of the project, you'll see that approximately 85% of teams are now meeting at least monthly. So this is a great win as well. Hard to get the work done if we're not meeting together. So as you know, in phase 1, we aim to be really geared in on the data, and we simply asked if you'd done an analysis within the last 12 months to understand what gaps you have in regards to readmissions. And at the beginning of the project, a quarter of you were really not even sure if you'd done this analysis, and less than half of you agreed that you had. But when we asked again this month, we saw this number grow to close to 95%. So well done. We definitely dug in and looked at the data. So after we had an idea of how many of you were looking at the data, we went a little deeper, asking if your readmission team was using that data to prioritize some improvement efforts. Basically, were you using data-informed strategies? And when we started, we were about half and half. But this month when we asked again, we saw that number climb to about 85% of you who agreed that you were using data to inform your improvement efforts. Lastly, we really asked you to be intentional about refueling your readmission teams, both in the hospital and across the care continuum. And I think you'll hear from your colleagues that although this seems very fundamentally simple, for many of us it was the single greatest win of the project. The value of creating organizational awareness, of ownership, of using a team approach across your organization and across your community was just critical to success. And so I'm tremendously proud of this cohort for achieving 100% in the post-assessment for collaboration. This is a really big, big win. And at this time, I want to invite some of our hospitals to share a few minutes of their refuel stories. And so please help me welcome Clark County Hospital. And our team at Clark County, Vicki Landy, if you're on the phone, just give me just one moment to get your line unmuted. Vicki, your line should be unmuted, so if you manually unmute, we should be able to hear you now. Welcome. Vicki, we don't hear you quite yet.
Can you hear me now?
Population.
Just a second, I'm unmuting all the lines, but we have a fair amount of background noise.
Yeah, that might not work for you. Okay.
Just one moment. Let's try again. Vicki, are you on the line? What we're going to do while we make sure we can get Vicki cued into her audio here is just move forward to our next speaker, which is Sioux Center Health. Again, I'm going to unmute the lines, and I'll ask everybody to please check their audio to make sure you are muted. Sioux Center Health, are you on the line?
This is Sioux Center Health.
Go ahead, we can hear you loud and clear.
Okay, you want to go to the first slide? I think that's the third one there. There you go, great. Okay, so at Sioux Center, we when we got our data, we really looked targeted in the population that we wanted to work with. So we worked with age 65 and older. And we worked with Avera, we're managed by them, and with their clinical intelligence reports. And so we looked at the discharge risk score, and underneath that you can see all the risk factors that they use to come up with that score for us. You can go to the next. And then so we have a structured huddle time every Monday, Wednesday, Friday, and sometimes we'll do informal huddles also if there's a need. But then we're working with our social worker, home health and hospice, and then our discharge coordinator, and our managers, and our care coordinators. We all meet. Usually this is after rounding with the providers, so then we can have a good evaluation of our patients. And then we look at those that qualify for the care transitions and those diagnoses there. And then you can see on the next slide our paths that we follow with those patients. So we're working with so many in our team now. I think it helps us get organized that way, so we're able to collaborate. That way we start with the hospital process with the diagnoses, and you can see those diagnoses on the bottom there. And then it goes through the flow. We're looking at risk scores, is the expectation then of discharge, whether they'll just get those phone calls or they'll get home visits. Our biggest thing was our follow-up appointments, I think, is sometimes what we were missing. Even with our nursing home patients that we were discharging, we would often find a PRN appointment time, but we're organizing it so we do have a scheduled appointment for them to follow up, so we don't have that readmission there. So, and then with the support of home health staff, just really following up. We use a lot of scripting with our care transitions, using our stoplights for what symptoms that they're seeing, if they should be seen sooner or later, or so kind of give some guidance to those patients that are home. And then, yeah, like I said, with our collaboration with all the departments there, and then even we worked on this together, all those departments, we understood what each were doing and how the role that we placed in there. So, and even being consistent with the patient, so they knew what to expect when they would call with our scripting and things like that.
We're getting a question in for you all, and the question is, can you describe your transition team and what's your daily census?
Well, it depends. Our average daily census is 6 to 7 patients. Today we have 10, just in our med-surg, but yeah, we would say 6 to 7 is our average census on the med-surg floor. That transition team, we worked with the clinic, we worked with our home health, our social work, and then our hospital leadership staff. And our nurse quality officer also worked with us.
We've also added our assisted living and this group also.
Great job, guys. Thank you so much for sharing. We're working on getting Vicki from Clark County dialed in. But at this time, I'd like to turn to Laura Coyle from VA Des Moines to share a little bit about their journey with REFUEL. Laura, can you hear us?
Yes, can you hear me?
We can, go ahead.
Okay, great. Can you advance back to our first slide? Great. Okay, so for us, we're really kind of interested in joining this project, just feeling like we needed to remotivate our group. We were definitely dissatisfied with our current readmission rates, and the other thing is we were really wanting to gain some outside perspective. As a VA facility, we're very, very lucky in that we have 130 VA hospitals that we can network with and communicate with very easily, but sometimes it's helpful to get some outside perspective of non-VA, what other organizations are doing. So we were interested in that. We decided to look at a target population of our patients who were discharged to skilled care. After listening to one of the webinars, and that was suggested as a potential subpopulation, we'd never considered that before. And when we pulled our data, we realized that was a significant portion of our readmissions. We weren't really paying attention to where our readmissions were being discharged to. So for FY17, about 29% of our readmissions were patients who'd been discharged to skilled care, and it was 27% first quarter, and then second quarter of this fiscal year it was 17%, so still significant. And then of those patients who were discharged to skilled care, we found that a significant portion had been going to our own Community Living Center, or CLC, which is attached to our facility. It's on our grounds. It's attached to our acute facility. So of those patients who had been discharged to skilled care, about a third are our own patients. So that was exciting to us because, you know, we have control over our own processes. So if there's something that we were able to identify as an issue, we would be able to implement interventions to make improvements, whereas working with the private sector or public sector skilled care facilities, we, you know, we'd be working with clinical partners in the community, but we really don't have control over, you know, telling them how, you know, they can organize their processes. So we kind of focused on skilled care in general, but even more specifically our own CLC. Next slide, please. So in looking at our data, we went back 3 years, and we noticed our readmission rates had been trending up. There was a 13% increase over that 3-year period, and obviously we were hoping for a reverse trend. So in looking at our FY18 data, since start of our fiscal year in October, we started out in October, or in FY, or in Q1, sorry. We started out in Q1 at almost 15%, which was our starting point, which was pretty terrible. And I know the goal for this group was to reduce by 12%, but in looking at our second quarter and the first part of our third quarter, it looks like we've experienced a 27% reduction between FY18 Q1 and Q3. So we're really seeing significant improvements. Next slide. So some future opportunities that we're going to be focused on are really wanting to increase the frequency and quality of our post-acute care stay assessment and monitoring in our CLC. When we reached out to them to ask them, you know, what does the care look like when the patient returns after an acute care stay? Is it different? Do they have increased frequency and quality of assessment and monitoring? And what we found is that they had one assessment per shift for the first 24 hours, and then they defaulted back to their routine assessments, which are quarterly for a full nursing assessment. And so we found that to be lacking or deficient for what we believe they need to have more monitoring than that and more assessment than that for a period of time. So we have now included CLC leadership in our readmissions group and are working with them on trying to determine what that new process will look like. How frequently will they be assessed, and how long will that last after an acute care stay, to try to prevent those readmissions and keep a closer eye on those patients. And then we'll monitor any change and see if that piloted process change has a positive impact on our readmission rates. And then if so, we would use that as a best practice with our community partners in an effort to try to convince them to adopt maybe some of those practice changes to help reduce readmissions in that population as well. Over this period of time, some of the things that we've done have been working on our medication reconciliation process. We were finding also that we were having a lot of issues with patients, especially going to skilled care, having readmissions related to not getting their updated medications that they should have when they had been discharged. So that continues to be a bit of a struggle with our community partners. We've resolved the issue for the most part with our own CLC, but that's something we've been working on. When we look at our lessons learned, we really feel like there was value in gaining outside perspective and being a part of this group. And then we really appreciated being able to choose this subpopulation to work on because it really, focusing on the subpopulation helped us be motivated and focused, and there was a lot of improved engagement from our group.
Thank you so much, Laura, for sharing the VA's kind of journey through this refuel project. And I think you're absolutely right. We heard that from many hospitals, that focusing in and working on a bite-sized piece really put some intention behind some of the strategies we were deploying as a part of this work. So thank you so much for all your work here and for being willing to share. I am going to turn now back to Vicki. Vicki, if you would unmute your line, we'll give it one more shot here to see if we can get you connected to the audio. Are you
Hello, can you hear me?
Oh, we can. Very good. Let me back up to your slide here, but go ahead and get started. We can hear you loud and clear.
Okay, so our admissions, what we did with our population was just made sure that we included all of our admissions. And we did have a decline in that stuff. However, I think with our readmissions, the biggest thing that we noted was that it wasn't just the responsibility of just one person or one department. By involving the different departments in the Refuel Admission Project, we were able to have a teamwork throughout our organization. And with that organization teamwork, we included Med-Surg, ED, social services, URQI, and infection control. And then we also, those departments were taking responsibility also, or ownership for those roles in the readmissions. Next slide. We included our the hospitalist, the PCP, the office staff, and also other people in the community with that collaboration. We had the home health, the nursing facilities, assisted living, and we also included our local pharmacies. Next slide, please. Our nursing staff were scheduling the follow-up appointments so the patients got their appointments sooner, but also the clinic PCC was scheduling the appointments more frequently if the patient needed it. So our discharge home visits and the soft handoff transition visits that we had was helping the caregivers in the facilities with reminding them of those follow-up appointments and reviewing those medication lists that helped with the questions or the concerns that they had with the medications. Next slide, please. So the biggest success really for us was a smooth, collaborative transition of care for our patients. Yes, we wanted to cut our readmissions rates, but really whenever it came down to it, our biggest success was the collaborative transition of care, and mainly because it's the right thing to do for the safety of our patients more than anything. So I would have to say that our teamwork was our biggest success. Thank you.
Absolutely, Vicki. Thank you so much for sharing. We are getting one question in for you, and that's who performs your home visits?
Well, actually, there's the discharge planner, which is myself, and Ashley Davis, who is a telemedicine nurse, and she fills in, or we both work together to get those home visits done.
Just a really great job. I appreciate you speaking and sharing, Vicki. Great job to the Clark County team. Thank you so much. Okay, so give me just a minute and we'll forward through a couple slides, and that really brings us into phase 2 of our work together. We made, again, 4 refueling stops during phase 2 of work. The first one was really focused in on understanding the root causes of readmissions, and secondly, identifying readmission risk and post-discharge needs, developing enhanced services that meet those needs, and then jumping into action as far as planning and making those improvements. So quickly, just a little more detail on the readmission interview strategy. We heard from many of you that this was a big takeaway from the project. And of course, the purpose of this tool is to really understand from the patient and the caregiver, from the family's perspective, why did they come back to the hospital? What went wrong? What was at what point did they make the decision? And so we can get a little bit more information on root cause from the patient's perspective. So we challenge you guys to go ahead and jump in and start doing those readmission interviews. And we learned very quickly in phase 2 of work that there were a lot of lessons learned. And I won't read all of these, but just to capture a few, we learned that we need to change how we do patient education. We learned that patients are pretty willing to discuss why they came back to the hospital. They're willing to give us that information. We just need to ask. And so another one is the family has really good insight into some of the problems. So these were all incredibly rich lessons learned from the readmission interviews. When we dumped these root causes or unmet needs into buckets, we saw that there were some system factors, right, that we had opportunities to act on, but there were also some patient factors. There were human factors that we really needed to consider and left us, again, just opportunities to act. So turning back to some successes captured in the pre and post survey, we knew that we weren't really always determining why our patients were coming back within 30 days. But you'll see by the end of the project that nearly 95% of you reported that you are now doing that. More importantly, we asked if, when you find out why your patients are coming back now, are you actually using this information? Are you using this intel to identify and prioritize some things for your readmission team to be working on? And at the beginning, about 30% of our cohort said yes, they were using this information. And this was just a basic opportunity that I think we had missed. So we came back and we tried to act on that. We said, go back and ask your patients why they came back. Take that information and act on it. And so on the right-hand side of your screen, you can see that you all went to work with this strategy specifically, and now nearly 90% of you are using and acting on this information. So if we're finding out from the data who is coming back, and we're asking our patients directly why they are coming back, are there some additional services and supports that we could design and deliver that would proactively help meet the needs of these identified root causes? So we challenged your teams to take a look. And so I think what we'll do is we'll turn back to some of the hospitals of the cohort to share some of their successes and lessons learned in phase 2 of work. Cass County team, the floor is yours. Go ahead and try and unmute, and we'll see if we can hear you. Megan, are you on the line?
Yep.
Very good. We can hear you. We can. Go ahead.
Okay. Well, at Cass County, the interview was something that was brand new for us. And I would say it was probably our biggest takeaway from the REFUEL project. So what we decided to do was use the interview on every single patient that was a readmission. So we started, as soon as that phase 2 started, we started interviewing every patient. And we quickly realized that we should have been doing this a long time ago. We had already in place a type of root cause analysis, but all it really included was reviewing like the patient chart and talking with the providers and nursing staff, and we weren't talking to the patient, which seems kind of obvious when you say it out loud. And so we quickly realized the importance of engaging the patient in that conversation. So I have a couple examples I wanted to share with everyone, some patient examples. The very first interview that our team did was a gentleman. He's a 91-year-old male who lives with his family, and he first came in due to congestive heart failure. And when he went home, he had no services, just went back with his family. They were his caregivers. And then he got readmitted, again with congestive heart failure, but they also found a pneumonia this time. And so when I interviewed him, he told me that he actually wasn't even feeling good the day we discharged him the first time. And since the time he had been discharged, he also had a follow-up appointment, and he wasn't even feeling good when he had his follow-up appointment. And unfortunately, he never disclosed that to the provider. or to any of the staff at the time he was discharged, but it provided a good educational opportunity with the patient to explain the importance of letting us know that type of information. So that was the very first interview I did, and I realized how eye-opening and important these interviews are. So then another example I have is a gentleman. He's an 83-year-old male who came in with COPD exacerbation. And this was a new diagnosis for him. He had been diagnosed in the last couple months, so it was a big life change for him. And he went home with no services and came back within a few days, actually, with the same issues. And so I met with him to do the interview. And as I was explaining, the reason we were doing the interview and what it would be like, he was very sweet, and he was just, oh, you guys did nothing wrong. There's nothing you could have done. I just have bad lungs. And I said, okay, well, let's just go through this interview anyway and see if there's anything we can come up with. So I sat down and went through the questions with him, and his wife was present as well. And when we got to the part about his medications, his wife spoke up and said, he was discharged on a lot of new meds, and it was very confusing for us. And we also didn't really understand how to use the nebulizer. So right away, it showed us that we needed to kind of improve our education with that patient and some teaching on medications. So we got respiratory therapy involved. We got our nursing staff involved to provide extensive education on all those new meds. And it was also a clue that we probably should have done that in the first admission. So those are just a couple examples of some things that we've learned by doing the interview. So of course, we're using that information to assist with the discharge planning for that second admission, to make sure everything's in place and all the education is provided to prevent yet a third admission. But we're also taking that information to our readmission team and sharing it with the team. And also it goes to our providers for peer review. Every readmission is sent, it goes through the peer review process at our hospital. So that interview is included in that. So we have decided as a team that we're going to continue to use the interview. It's something we're going to do from here on out on every readmission. So we're really excited about continuing that and seeing what other information we can learn from that process.
Thank you so much, Megan, for just sharing those insights. I think just the examples you give on some of the interview really captures, I think, the essence of why it's important to talk directly to the patient and their family. So great lesson learned, and thanks for your willingness to share. We're going to turn now to Audubon County Hospital and ask them to share a little bit of their work with the Readmissions REFUEL project. Emmy, are you on the line with us? Emmy, if you're on the line, I think I see you there. Go ahead and unmute your phone line.
Can you hear me now?
I can hear you now. Go ahead. The floor is yours.
All right. So the first thing we did when we started looking at our readmissions was we actually built some of the initial readmission interview questions into our assessment. This way, as soon as the patient got there, the nurse could see kind of what needs they had. Maybe it was that they didn't understand a discharge instruction, or maybe there's a lot more to it that they just didn't have the services they needed. So as soon as they were admitted to our floor, those interview questions were asked by the admitting RN. There's just a general area at the end of our assessment that says if the patient has been readmitted within 30 days, please continue with these questions, and then they go on from there. We found this to be really helpful when we had a readmission of a 94-year-old female. She had come in from the long-term care facility nearby for the second time this month with pneumonia. And we got thinking, somebody is managing her medications, she gets the help she needs, but why does this keep happening? So the doctor and I actually went into the room and kind of got to the bottom of it and asked a few more questions, and we found out that she was not wanting any further interventions done. She had been aspirating, causing the pneumonia, and she realized that she wasn't going to be a surgical candidate and she didn't want to have a scope or anything like that. So what we could do with that was we informed the nursing home of her wishes, and we put a note on her chart, and just she didn't want to be readmitted anymore. She just wanted to stay in her home at the long-term care facility. So we were able to talk with them and our staff here and say that that was her wish, and she hasn't came back since. So I know that she's getting well taken care of there and being comfortable in her own home, which was good. If you want to go to the next slide. So the next thing we did for our readmissions was we started to meet with one of the long-term care facilities nearby. We met 3 times over the lunch hours to help talk about alternative routes for their patients rather than sending them to the ED. We had been seeing that a lot of our ED patients were coming from the long-term care facility nearby. And we kind of got to the bottom of what was going on and why they were coming. And they also brought concerns to us about some of their patients, which was really good. We have a very open line of communication with them now. So we kind of zoned in on a few individuals who had been coming back to the ED, and we had been sending them back, and got to the bottom of why they were going back and forth. Since then, our providers have been updated on different things, and they're doing more rounding at the long-term care facilities in the area. Different providers go on the different weeks, so that if they prefer one provider or the next, there will be a time coming up soon when they are able to see their favorite provider. And then all of our providers do have access to the other notes. So rather than somebody coming to the ED or us not having access to their chart, all of the providers can see what the other provider had already worked on. And this has also opened up our communication enough with them that we're going to include them onto our Falls project that will be starting here shortly.
Really good work, Emmy. Thanks so much for sharing. I think just highlighting your work with the readmission interview tool and how that impacted plan of care, and then also how you've really reached out into the community to build these collaborative partnerships. So very well done. Thank you so much. Now we'll move over and ask for our colleagues at Clarinda Regional Healthcare Center if they can hear us. If you're on the line, go ahead and unmute. The floor is yours. Jill, are you on the line? If you're on the line, Jill, go ahead and unmute your phone line. I'll give Jill just a minute.
There we go. Can you hear me now?
I can hear you now. Go ahead, Jill.
Great. Okay. When we did our analysis, our highest readmission population were COPD and pneumonia. So along with the chronic care management, we decided to look at COPD patients, the closest. And there were some opportunities. Reason for the concern was we wanted to do a comprehensive management and early identification of patients with COPD versus catching them when they were moderate to severe. We want to catch them earlier in the disease process. The goal was to identify patients early on, integrate the identified patients into a multidimensional chronic care management plan, and we are kind of piloting, we're using a standard screening tool and going to pilot it with one physician in the clinic to start with. And they created a clinical pathway as to how they score out on that CAT score, as to what will follow. And our cardiac rehab and respiratory therapy department are champions of this COPD project. And they are hoping to screen patients 35 and older that present for chronic care management visit or with an acute respiratory complaint. They created a spreadsheet that will track all patients that are screened, their score, the date of the screening, and if a referral was made for PFT testing and follow-up. The tool will also be used to track disease progression over time. They'll also get a CAT screener score for patients already diagnosed with COPD. The clinical health coach is also going to work with those patients and the team, and they're developing patient education, which will include explaining what PFT testing is. So, Carrier couldn't be here with us today, and Lori's busy, I think, so do you have anything to add? And the process is still ongoing, so we're hoping that will help with reducing readmission.
Well, I just love that the work that you've done in phase 1 and phase 2, you've really honed in on a target population, identifying that you had this great area of opportunity with your COPD patients specifically. And not only then did you evaluate the data, target a patient population, but you really jumped in as far as designing some enhanced services and interventions that would maybe meet the needs of this specific patient population, going so far down the care path to try and identify these patients long before they're ever even admitted to the hospital. You're trying to catch them earlier at diagnoses, knowing that then you have a quicker and better chance of intervening so that they stay healthier. So I think that this is an incredibly proactive approach, and I commend you guys for all your efforts. Thank you so very much for being willing to share today.
You're welcome.
So with that, I think we'll go ahead and jump right into phase 3 of work. Phase 3 also had our 4 refueling stops. Firstly, view the ED as an opportunity to reduce readmissions. Secondly, increase treat and return pathways and opportunities for patients, specifically from skilled nursing facilities. Facilitate reach in and transition out for established care teams, and then utilize ED flags and care alerts to help inform the decision to admit. We're going to try and make up some time in these next few slides, so I won't go too deep into detail here, but really what we focused on is that we've been taught that the best way to reduce readmissions was to improve the transition out of the hospital, but we've been able to see nationally that there's some innovative teams that have identified opportunities to reduce readmission when the patient presents to the ED, so prior to the decision to readmit. And so we utilize some of those strategies in phase 3. So what we wanted to do is move kind of to a different mentality, which is really increase the frequency of evaluate, treat, and release when it's safe and appropriate. We gave you access, if you didn't already have them, to some really great resources, the Interact tools, the nursing home to hospital transfer form, and the nursing home capabilities list, and encourage you to use these tools as you have conversations with your local skilled nursing facilities. We knew from the pre-survey that engaging the ED was going to be new for many of our hospitals, but over the project we really saw the percentage of hospitals engaging their emergency room and their readmissions teams grow by about 50%. So really great job here. One of the key factors with engaging the ED is being able to identify real-time the patients who have presented to the emergency room within 30 days of an acute discharge. So we asked you to take a look and see if you have some sort of mechanism internally to identify those patients who come into your ED. And when we asked at the beginning of the project, you'll see on the left-hand screen in the yellow bar, there was a good percentage, about 50%, who were unsure or knew that you could not. And so when we asked this again here in the month of June, now we have at least about 60% of you now reporting that you're able to identify these patients real time. Lastly, we asked you to consider treat and return pathways when possible. And we knew from the pre-survey again that this wasn't a widely used strategy. Again, pre-survey results are on the left-hand side of your screen. And so, you know, this was a phase 3 strategy we worked on the end of April and throughout May, but we knew when we surveyed you again in June, you may not have had a chance to fully implement those. So what we did was we added a column at the bottom to capture those of you who were in the process of building one of those treat and return pathways and implementing that. And so over half of you had or were already in the process of doing so when we took a look this month. So, and now I think what we'll do is we'll turn to our team at Knoxville Hospital and Clinics and ask them to highlight some of the work that they did in phase 3 of REFUEL. Knoxville team, are you on the line with us?
Hi, Kate, we're here. Can you hear us?
We can. Go on right on ahead. The floor is yours. Thanks.
Okay. Well, Jill Sage is here. She's our case manager, and she's going to talk about a couple different things. If you want to, I think that's right. Yeah. Can you hear me okay?
We can.
Okay, good. Like Ellie said, I do case management, and our UR nurse Lisa is sick today, but I'm going to go over her part on the slides. Lisa's very active with the ER every day when she's at work, and keeps an eye on who's coming in, and you know, really watching if they're a readmission or whatnot. And she is very good to work with the provider in the ER to discuss the case and look at options as to, you know, whether we can possibly just readmit them to skilled care again if it's just a matter of weakness or, you know, families unable to care for them at home, things that sometimes bring them back within those 30 days. So we have been able to do that. And then if the patient is not felt stable enough to skill, then they have a conversation with Lisa about maybe doing OBS and seeing if those labs and things can come up over 24 hours and then move to a skilled bed. Just to kind of, you know, have that conversation. And we really have noticed that the providers are more and more aware of that. Our regular providers in the clinic are, you know, thinking about that even when they see people in the clinic. Hey, you know, I know this person was just here, what can we do? They're seeking it out also, and they have been very cooperative and really like the guidance there. Of course, when Lisa's gone overnight or on the weekends, our resource nurses are also trained to recognize those things and have been successful in recognizing that. And then the next slide here talks about the Interact form, which was a few slides back, the form that you folks had given us. We did send those out to our nursing homes that we work with, and they were returned within 2 hours from all of our nursing homes. So they were very eager to participate and showcase or let us know what all the capabilities they have, which we had kind of discussed before, but it was really nice to have it all in one sheet. Those forms were very helpful. And then we did share them with our clinic manager, Holly, so that she could get that out to all the care providers in the clinic, and also was shared with the ER manager. Just to kind of, like this slide says, start the conversation about maybe changing the way we look at care, and maybe finding a way that would be just as effective to treat the patient, but maybe less costly, and also keeping the patient, I think, like we said before, in their home, in the nursing home where they're comfortable and they have a routine, and especially those people with dementia and whatnot that a hospitalization is sometimes very hard on. So that has been helpful, and that's a work in progress, but we really like the forms, and the nursing homes really liked being involved.
Great job, Jill. Thank you so much for just sharing a little bit about how you've engaged with your ED and also kind of pulled in your skilled nursing partners to leverage strategies for treat and return pathways. Great job. Thank you for sharing. Okay, well, let's move forward and let's try and tie some of this all together. At this point, I'd like to welcome our colleagues from Van Diest Medical Center to share some last stories on how they've used this project to refuel their approach to readmission. Van Diest team, are you on the line? Denise, the floor is yours. If you are on the line with us, go ahead and unmute your line.
I'm, yeah,
Denise, can you hear us?
I can hear you. Can you hear me?
You can. Go right on ahead.
Okay. So when we first started this project, we not only looked at the reports that the HIN gave us as far as our facility-specific readmission information, but we also looked at our own data, and we went back 12 months and just looked at all the readmissions we had and specifics on each one. And it was pretty evident after reviewing our internal data that Medicare patients that had CHF that we were sending home were the most frequent offenders of readmissions for us. So that's why we decided to work on that population for this project. You can go to the next slide. So we did a rapid cycle improvement process, and we sat down as a team, and on our refuel team, we had disciplines. We had me as the UR nurse, we had our case manager, our social worker, we had clinic staff, health coach, and somebody from the ER come. And we decided that we would institute these 4 interventions for these people, and they were CHF education binders. And in those binders were 4 different tabs for very easy to access discharge instructions, resources, education on medications, and also we put the red, yellow, green stoplight charts for CHF in those binders. And the nurses initiated those binders when these patients were admitted. Any CHF patient with a primary or secondary diagnosis of CHF, this was initiated with. We didn't wait for the readmission. We did it with the first time they came in. And then the third thing we did is we made sure that our pharmacists met with these patients one-on-one prior to them going home. And we have a younger, newer pharmacist who does really good with patient interaction. And he loves to sit down with these patients, and they have really good conversations about their medicines and any new medicines. And I think that's really helped patients, because sometimes they go home on 10, 12, 20 medicines, and they need a little extra help with that. And the fourth thing is, if you had a diagnosis of CHF, we automatically just followed you for 30 days. So if it was somebody that the health coach could follow, she would give them weekly phone calls and see how they were doing, make sure they were going to their follow-up appointments, answer any questions they had, talk about their symptoms, ask them if they're weighing themselves, things like that. That helped us to make them feel more supported at home, and also it helped us to identify if they had some needs at home, and it just helped that transition. So that seemed helpful. And we also, as part of our readmissions team that meets monthly, we give our physicians a monthly report on their specific readmissions that came back the previous month. We meet as a multidisciplinary team, and we just kind of go over specifics on the readmissions. We do timelines. We talk about if it was preventable or not preventable, and if there's any suggestions, we also put that on there. And then each physician at med staff gets their readmissions. So it kind of keeps them more invested and engaged when they get feedback every month on what they've done for readmissions. Next slide. So our big wins, I guess, are, we have a lot stronger partnership and collaboration with the clinic and the health coach team. We meet routinely, and we are working real well together. And we've also, like I said, that helps us develop that team-based approach. And we were able to increase the patient engagement in their healthcare just by having that health coach kind of be the resource for them. And they've developed good relationships with the person who's staying in contact with them for 30 days. And we also increased our physician engagement just with giving them their feedback, and it just makes them more aware of how they're doing, and also makes them aware that we're paying attention to readmissions. So those were our big wins. Our initial data shows that I took our readmissions from January to May and compared them to last year's January to May. And as far as CHF readmissions, it was a 20% decrease. Overall, our rate's down 1% from last year at that same period. So it's a work in progress. And you know, when you have varying censuses, your readmissions rates vary greatly too. But like I say, we're seeing some positive effects anyway on those CHF patients. And also as a part of this project, we were able to form a more intensive case management team, that if our readmissions team identifies somebody that needs extra help or extra guidance, we refer them on to that case management team, and they meet every other week and just discuss interventions to help the certain patients along. So that's our REFUEL project.
Mm-hmm. And she makes it sound all so simple. Thank you so much, Denise and Vandy's team, for being willing to share, I guess, your journey through REFUEL and some of the successes that you've had. Your team's done incredible work, so thanks for sharing. Lastly, but certainly not leastly, and I know that we're coming up to time, but we have one more hospital on the line that we'd like to share. We're going to turn now to our colleagues at Grinnell Regional Medical Center. Are you on the line with us?
We're here. Can you hear us?
You absolutely can. The floor is yours. Go ahead.
All right. Hello, everyone. Andrea here. I'm the transitions coach at the hospital here, and I'm just going to give a general overview of kind of what we did during our project. So the patient population that we chose was sepsis, patients of any age with sepsis, and we picked that after reviewing the data we were provided at the beginning of the project. So different interventions that we did here during the project, we added sepsis as a diagnosis to our already established transitions program. So with that, they would get diagnosis, specific education, the weekly calls by the nurse, and early intervention as needed for patients, even while they're still at home. We altered our high-risk tool that we were already using, so we added sepsis as an always diagnosis. So anybody coming in with sepsis would automatically be a high-risk patient and be followed closer after discharge. And then also on the high-risk tool, we changed the patient age to basically catch anybody over the age of 65 instead of over the age of 80, which is what we had previously done. And that was also based on the data that we received for readmissions that showed that people were actually a little bit younger with their readmission. Interventions for the educational handout. So we developed a handout for sepsis to hand out to patients, like a very concise, easy to read, and that education then was started while they were in the hospital. Then they could take this handout home with them to use after they went home as well. And we did develop the handout and then had our patient family care council approve the handout so that we knew the patients were considering it easy to read and useful. So, and then during our experience with the readmission interviews, we had 5 that were completed during the project, and in attempt to investigate the root causes, and it highlighted areas that could help avoid readmissions in the future. And then I just included an example. So we had an elderly female patient readmitted with COPD. She initially went home and did note that she was declining, but her go-to person for calling the doctor on her behalf or getting appointments was her daughter. And she, during the readmission interview, noted that her daughter never answers that darn cell phone anyway. So we then were able to talk to her about alternate ways to get a hold of help if she needed that, whether it was calling me, who was her transitions nurse, or having maybe one other family person that she could call in the event that this daughter didn't answer her darn cell phone. And then just a couple numbers here that I thought were interesting. I added between January and March, we had 9 readmissions. One of those was a sepsis readmission. Overall patients that we had in the hospital with sepsis as a diagnosis was 12. So here's where the numbers were kind of showing what our interventions kind of, how they made a difference. So of the 12 patients with sepsis, 5 of those would not have been part of our transitions program. So they wouldn't be sepsis, pneumonia patients. So we caught those patients extra. And then of the patients that I mentioned just now that we caught, 4 of those would not have even screened high risk because of maybe they were young or what have you. So we were able to gather a lot more of the patients and watch the patients closer than probably needed it. And then as far as our emergency room involvement, we have a pretty small hospital, and they are very, very good about reviewing last day information for every patient. We also have a couple of internal med doctors that are very good about also looking at that information when they are seeing patients up in the ER, and they do go up and see them in the ER usually. So they're aware of the potential readmissions. And then an exciting thing is that we are going to soon be getting EPIC, so we're going to have a lot more opportunities to come up with a more formal way of flagging patients when they come in. So that's kind of on our near future to-do list. And then just as a wrap up, participating in the project has allowed us to use specific data to identify a patient population that had not been recognized, and we have improved our education, our follow-up, and early intervention for our patients to reduce readmissions.
Absolutely great job, Grinnell. Again, I am so grateful to you and everybody else who participated as presenting today and sharing kind of your experiences and lessons learned. As we kind of conclude this project, and again, I know we're over time, so I'll wrap this up quickly, but I think this is a great example of how you guys can continue to leverage each other and the Compass 10 network as you continue your readmissions work. Use these lessons learned and use each other to continue refueling your strategies. I'll encourage you to contact your assigned clinical quality consultant to request additional coaching support and as you need it. These webinars that we did as a result of the project are all recorded. They're all available as resources to you on Innovation, and they're not going away. So, you know, revisit them and use them as education tools when you bring on new members of your team, and continue to reach out to us at Compass 10 to help support you. In regards to data, I want you to think about when's the next time you're going to pull the data again and take another fresh, comprehensive look. I mean, I know we're looking at it every month now, but when are we going to pull it in big time again and re-strategize? And so our goal for Compass 10 is to be able to provide you all with another facility-specific readmission report in the fall, and we'll be sending those out to continue helping your data strategies. And then lastly, just a reminder and a mention, get to a fueling station. Don't let the work stop here. Readmissions work, you know, in a sense, it will never be over, and it's incredibly challenging. So continue to refuel your teams, refuel your commitments, your data, your knowledge, your strategies, continually and intentionally, so that you don't run out of gas. And as far as next steps, I want to make sure that you all hold the date for September 25th, which is the next in-person HIN learning community. And we heard from many of you, you know, as you looked at readmissions, just the focus on end of life and palliative care needs. And the next learning community is focused all around end of life and palliative care. And we'll be sending out a save the date for that in the coming weeks. So we hope to see you all there. I want to again thank you for your incredible work and commitment to the Readmissions Refuel project. Thank you so much and have a great day.